Presentation. Thank you very much. Anybody have any questions for Dr. Martin? I think everybody been asking MyVal for more evidence, and this has been given with this kind of trial, and we are looking for the 10 years and 5 years follow-up for this trial. Availability of sizes for sure makes our life easier in terms of thinking which valve to go for, and with very predictable sizing rather than adding and removing CC, much easier. A very nice trial, and I think we'll be looking for the follow-up in a few years as well. Are they ready for us in the site or perfect? So we are expecting a live transmission from György Gottsegen, a National Cardiovascular Institute from Budapest, Hungary. We have two very senior operators, Dr. Peter Andrika, which is the head of Department of Adult Cardiology in Gottsegen, Hungarian Institute of Cardiology, and Dr. György Fontos, which is also the Chief of Interventional Cardiology of Hungarian Institute of Cardiology. I don't know if they are with us. Dr. Andrika and Dr. Fontos, you're live. We can see you.
Hi, you can see us, right? Hi.
Yes. Hi.
Hi. Good morning. Good morning, Dubai. How's the weather in Dubai now?
Well, weather is great. Everything is great. We're looking forward to see your case.
Okay, very good. So, dear Chairman, dear panel, we are the Gottsegen National Cardiovascular Institute in Hungary, Cardiovascular Center in the country, and we are dedicated exclusively to cardiovascular medicine. We are covering the entire portfolio of cardiovascular medicine, starting with the pediatric cases and finishing it with the octogenarians, heavy patient population. So first of all, please let me introduce you our team. György Fontos, my friend and colleague, is standing right next to me. We will be doing the case together. Our scab nurse is Zsuzsa. She will be helping us. The patient is constantly sedated, but we have an anesthesiologist in the room. Keva is standing right there, and we even have a nurse anesthetist, Melinda, who is standing behind Keva, and we have an echocardiographer in the room, Anita, who is there right next to the turned on echo machine, which is definitely mandatory during a case. No matter we were planning to use it. The echo machine is equipped with a transthoracic probe, a probe, and a linear probe. We have fellows from all standing right behind us. And we have a junior fellow, Noemi, who is standing outside, and she will be introduced the case. Noemi, it's your turn, please.
Good morning, everyone. I hope you are a wonderful day. Our patient today is an 80 female with hypertension, 2 diabetes. Her aortic stenosis was diagnosed in 1, and ever since then she was under constant follow-up. During one of these checkups, atrial fibrillation was detected under routine, so she to coagulation therapy. At the end of 2022, her aortic stenosis became severe, and also of 2022, sinus rhythm was established by a cardioversion. We first saw her at our institute this year when we underwent coronary angiography and an echocardiography. On this latest echocardiography, we now saw a mildly reduced ejection fraction of 45 with no motion abnormal and a stroke volume index of 25 milliliters per meters squared. The valve was cast with barely so low and aortic stenosis. The grade is 51/35 millimeters of mercury, and the AVA was 0.5 centimeters squared. During the coronary angiogram, we saw overall sclerosis of the right and left, and we also saw a distal LAD stenosis. As in the protocol, patient's case was presented to the heart team at decision active tower.
Okay, thank you. As you could see, there is some LAD stenosis of this patient, but she's chest pain, and we are not planning to that LAD stenosis. I would just like the opinion of the panel. Do you agree with us, or you would go for another solution?
So, Dr. Napti, what do you think? Would you do anything for that LAD, or would just go ahead and do TAVI?
No, I would fully agree not to do PCI in this lady and just proceed with TAVI procedure.
Let me ask this.
Oh, you do agree with us?
Anybody for PCI in this case? No? Okay. Yeah, we all agree that just go for the TAVI and skip that LAD.
Okay, very good. The patient is lying already on the table, so please take a look at me with the cameras. We have left radial access for the pigtail. We have right access for the Python sheath, and we have a right jugular access for the pacemaker wire. And as I told you, it is conscious sedation, but we have anesthesiologist team in the room. It's mandatory. So we are trying to follow a so-called minimally invasive procedure. But of course, minimal invasiveness of a procedure depends on the situation and the clinical status of the patient, of course, and anatomical difficulties, the possible anatomical difficulties of the case. So first of all, if you agree with me, let's take a look at the anatomy and the CT of the patient. Show us the CT. Okay. So that of the aortic valve is 460.7, and the area-derived diameter is 4.4. So if you the chart, the sizing chart of a MI valve, because it's going to be a MI valve implantation, according to that chart, we have a 26 millimeter valve, which gives us a 13.5% oversight. But there is a slight, take a look at the SOV, are smaller, narrower than the ideal. So we have an idea what to do like that, be on the safe side, or at least the safer side. So plan today is to go for a 4.5 millimeter MI valve, which gives us a 0.8% oversize. The volume of the balloon, of the deploying valve, the balloon of the 24.4 millimeters, 20 millimeters. So the plan is to put 5 millimeters extra volume. One will be used for de-airing. It means that we are going to use 24 millimeter contrast to deploy the valve, which will give us approximately like 10-11% oversize. What do you think? I'm just wondering whether you agree with us or not. That is a great advantage of a MyValve system, that you can have intermediate sizes. So we are planning to use this 24.5 millimeter valve size. What do you think?
Dr. Enrique, sorry, I didn't get the idea why you are not trying to use 26 valve right away.
Yes, because of the sinus of Valsalva, that I mean, because of the at that point, we think that the valve and the balloon itself, the shoulder of the balloon itself, will be a bit too large. So we think that it's just safer to go for a smaller balloon, extra volume.
Well, from my
It gives us a 10% oversize.
I will ask our panelists here from what do you think? Who does have any opinion about this? Okay, let's start with you.
Yes. So does we know the calcification amount of the annulus? Is this the?
I'll show you in a minute.
Right.
It's a kind of a mid-size calcification. Show us the next slide. You can see that's a tri-leaf flat valve, and please go show on. So we have like a medium to moderate classification of the valve, I mean the mild to moderate classification of the valve.
Right. What do you think, Fahid?
Yeah, I had similar question about the calcification because I'm worried about. I think to my eyes it looks like not a lot of calcium, and worried about stability of the valve. I would like to know about the leaflet height and more information to give us risk stratification for coronary obstruction.
Right.
In this situation, I think 26 valve would still be feasible, and actually, I think more appropriate in case that you don't have significant calcification. Your sinuses are good. You're almost more than 27 in all sinuses. So I think using 26 at nominal would still be useful and more appropriate sizing. I think choosing 24.5 and then adding 4 cc may get you there, but you are actually running the risk of paravalvular leak or valve instability in this situation.
What do you think, Dr. Adil?
Yeah, my valve is a very forgiving valve. I've used it with like 4 cc's, but in pure air, I had bigger sizes. In this case, I would probably go with 26 with less volume. This is my, because it gives you more room in case you need to inflate later on. Both coronaries are high. I agree that the sinuses are small, but I think if it's my case, I would have gone with 26 minus 2 to start with.
What do you think, Dr. Nikki?
That's another great comment. So we could do that actually. So the volume, the balloon volume for 26 will be 23 millimeter. So with like 2 mLs less, it would be 21, right?
What I would do, Dr. Enrique, like if it was my case, I would just go 26 minus 1, just like what Dr. Adil was saying, and deploy 70-30 or 80-20 even. In this case, your coronary heart is fine. Even if you obliterate your sinus of Valsalva, it still is 28, 27, 29, as I saw it, so it wasn't that bad. If you put 26 and it's underexpanded a bit, you will end up maybe with some pinwheelic, but I think better chance of not having intravalvular AI if you're going +4 at 26.
If you allow me for just a comment or question in this one, because if you go back to the documents from the IFU by the manufacturers themselves, they did not recommend minus at all, 0 minus. So they did not recommend minus at all from the manufacturer point of view. The other thing, this valve is, if I am in the doing this valve, I will do 27.5, not 26. So it's the 26, even still 13%, which is the usual, the initial recommendation for the emphasizing or the is 12.5. Why we go, the time goes more, we go less and less.
Right.
I would go 26 as it is, without minus, without it. You have a very spacious sinus valsalva. The coronary high is good. why we need to go minus, why we need to go 4 plus. For sure, I will not go 27.5.
Okay, nice.
Yeah?
So you hear the cohort. It's your decision at the end. We
Yes,
are here.
I heard. Yeah, I heard everything, and I really appreciate it. So we'll see what's going to happen. I hope that you are not right, because we have the already loaded 24.5 millimeter valve with a full mass of extra. So we'll see what is going to happen. We are not planning to challenge the valve very much. However, someone just mentioned that it's a pretty forgiving valve, so it means that basically we could choose either way to go for the either with no extra or with some less, and the 24 with the extra. So we'll see what's going to happen. Okay, we with Geza are pretty confident that it will work nicely. We'll see. Geza, what are you saying? You don't have a microport, so so our workhorse wire is the Confida wire. So I'm going in with the Confida.
How much for shortening you are expecting with the 4 plus in the 26? In the 24.
Yeah, so that's the advantage of the smaller valve. So we don't expect much foreshortening. So that's why the implantation will be 30 and 70%, 30 towards the LV and 70 towards the aorta. We do not expect much shortening, to be honest to you. But I'm going in with the Confida wire.
Yes.
Ultrasound guided, but
you can go ahead and
you.
we will take questions from the audience as well at the same time, if you don't mind.
Okay, let me show you the puncture. You could see it was an ultrasound. You can see the bifurcation. The next one, please. The bifurcation in the common femoral. Down, you can see the femoral head. The next one, please. The next one. So in the middle, you can see the of the common femoral artery, please. You can see that we are pressing the skin above the next one. Very good, and the next one, please. Okay, the needle has entered the common, and then you can see the wire in the middle. We always check it whether it's not subintimal or not, and please show us the next one, the last one, and then you can see that it goes into the femoral artery nicely above the bifurcation. And please show geogram of the sheet. Angiót szeretnénk kérni. So the puncture is right in the middle of the bifurcation and the inferior epigastric artery. So it was a safe for the large shape.
Nicely done, Dr. Nguyen.
Okay, no, that's fine. I'm going in with the Confida wire.
Thank you. I just want a quick comment here. We have established data for balloon expandable valve, although with a different platform. And I just want to ask the people who are commonly using this valve, for each level of stress that you endure in a balloon expandable valve, how much central AI are you going to use? This might not be relevant to somebody at the age of 80, but if you are putting 4 cc's and 6 cc and claiming or saying that this valve is forgiving, you don't have any long-term data with the durability of this valve, nor the effect in oversizing and central AI. The second part that I do like about this valve being forgiven or have a long sizing chart, it becomes very confusing to the operator when you give them so many sizing options. So I just need to hear from the people who are familiar and experienced with this balloon expandable platform, is there any data to say that this degree of oversizing 4 cc not going to lead to leaflet stress and central AI?
We are going for the, we are going for the pre-dilatation. It's going to be a 20 ml balloon. I'm doing it. Okay, rapid pacing, please, 180. You can go.
Please start.
Yeah. 80.
Do you commonly base?
Okay, very good, very good. Okay, the contrast.
Do you routinely predilate this valve?
Okay. Spacing stop, please. Spacing stop. Okay, please go ahead. I'm sorry to interrupt you.
No, the question was if you routinely predilate when you are using the MyVal.
Yeah, yeah. Sure. Mm-hmm.
All right. So, Dr. Al-Goufi, I think I will just answer that quickly. You can continue with the case as we have 9 minutes for the. I'm not trying to rush you, but we have a benchmark. We had done some benchmark, but for a different balloon expandable for the Sabian platform. The most forgiving size is 29. We went up to +7 and without any intra-annular regurg. For a 23, we did not go beyond 2. And you would have some regurg. And same for 26, nothing beyond 3. This is what we got from the benchmark testing.
And Dr. Faisal, actually, the company released recently apps that just put the annular sizes, then based on the measurements, there is apps that will give you the most appropriate size. I think they use it here in the same case. So for these different sizes, it can make things maybe easier.
Good, well, good. Well, faster, what you say? Faster, better.
Using the new octa-core.
Is that the octa-core or the older version of?
That one, that's the older one, not the octa-core. Nice. So, last station. Let's go for the overlap, please. The cusp overlap, we are using the cusp overlap technique, RAO 0 and caudal 27. No. I'm going a bit further down and then I'm coming up to align the valves. So the orthogram, please. Let's go. So, how do you like this position?
I think it's a bit high if you want to go for a plus 4. What do you think? What everybody think for the balloon? For you're positioning up to the second white line, isn't it?
Yes, that is true. That is true. So that is a bit too high, right?
Yes, this is a bit too high for.
Yes, I fully agree. I fully agree. So I'm going down with approximately 1 millimeter, right? A bit more. Okay, I'm going down a bit more, and then I'm gonna adjusting the position with pulling. So when I pull, the valve gets more coaxial to the ascending aorta. So that is that position, I think, which is, I quite like it. No, that was still too high. So what do you think?
Looks better now. That's better.
Yeah, it looks better. I don't know for a +4 from like this is good. This is good for nominal. Like I start deploy 80-20 now. I don't go for 0. But this looks good for nominal. So if you want to accommodate for a +4, if you don't think it's going to force short, this is good.
Good. Okay. So our technique is, so we quite like to be not that fast with the. I'm not talking about minutes, of course. I'm talking about seconds. And then we're going to have a chance to just reposition the valve a bit if it is needed. Okay. So that is the plan. So please go for control pacing. I mean rapid pacing. I'm sorry, I was mistaken.
Did it went up a bit?
180. Right? Let me see. We have a slight problem with the pacing, so
I think it went up a bit as well.
who's this? Who's this? Who's this?
Yeah, it's,
Who's the daughter? Okay, please stop pacing and let's just. Sorry, we need to readjust the pacemaker wire.
take your time.
Kicsit visszafelé, csak a balra lassú. Próbáld egy kicsit lefelé.
Looks like it. Looks like stiff wire. It's not balloon tip.
Oké, most?
Cheap way.
Yeah, very. Let me just check it. Okay, let's do it. Okay. Okay, go for that. Very good. Stop pacing, please. Okay, so let's see. So let's remove the system very gently. And we're gonna park the valve. Yeah.
You want to start pacing the patient or?
Okay, very good. Please turn on the like 70 per minute. Yeah, we need to stabilize the patient because he needs some pace.
Yep. Good idea.
Okay, so good. No. Okay, not to try no. So we are coming down with the balloon. Good. Okay, so we're gonna check the tracheal. Oh, and the pigtail please. We're going for hemodynamics as well. Ne dobjátok ki a ballon.
Nice pictures.
Tessék? Okay. Yeah, we are zeroing the system carefully. Flushing and okay. Noemi, anda play. Another zero, please. Mega zero.
Transradiography. Please. Yes, thank you. I've measured maximum of 3 millimeter mercury, so practically no gradient. And there is a very small regurgitation. Maybe it comes from the place of the wire.
Looks good.
So it's echocardiographically, it seems nice.
Yeah, looks great.
Can you show us a short axis, please?
Yeah. Yeah.
نحن شو بدنا في فرق بالليك في بيور نايل.
You gonna perform a route.
So can you see the hemodynamics?
Very nice. Very nice.
So you can see the hemodynamics. There's no gradient. The diastolic separation is good. Even if you take a look at the it's pretty good. So hemodynamics, we do not expect any major fatigue. Anita, what is your opinion? So the index is 32.
So I saw a small regurgitant jet. It can be seen on
I guess.
picture. And I'm trying to
Yeah.
Short,
the
short
parasternus short axis view, but it's a bit technically. One moment. So seems from the parasternus view small jet.
You gonna do any final shot at the end?
See, there's one at the
We will definitely, we will. We're just waiting for the echo. We will.
يسوون الفيجرام ولا
Okay. That's fine, Anita.
From the
The
short axis view seems small.
the pericardium is empty, right, Anita?
Yes, it is.
Okay, the mitral valve.
There was a regurgitation
we had
jet
it.
on the mitral valve, and it didn't become bigger than it was.
Okay.
And there is a small tricuspid rigor, the same as it was before the procedure.
Very good. Oh, okay. So. I'm going to remove that from here. I'm going to remove from the for the final shot. Very good. Okay, so as you can see that there's no parallel, so this is we're gonna evaluate both the depth and the overly. Please push the table up a bit just to see the entire LV. That is good.
Patient is back to lift bundle now as well. That's very good.
Yes, that is true. That is true. The pressure is pretty good. Anita, please your hand from the X-ray. Okay, just your hand is out. Okay, very good. Kicsit parallax, please go a bit with more. No, back to a bit more caudal. A bit more. That's good. Perfect. Okay, it's here. Okay. 10 at 20. Let's go for that. Okay. So, final result. What do you think?
That is very trivial AI, I think. I think this is
Yes.
why this will seal. But otherwise, this is very good with expanded valves. 80-20 looks fine.
Yeah. So, what about the left main and the coronaries? They look open to me, right?
Yep.
So, there is no paravalvular leak. The gradient is okay. So, I think that we can stop here, and I'm pretty satisfied. Geza, what do you think?
Well, Dr. Enrique and Dr. Fontes, congratulations. You convinced us that 24 is 0.5. That was the correct sizing. Even we have still some skeptical faces here, but you convinced the panel. Congratulations on that. Well done.
So if you wish, then we don't have a control. So if you wish, we can take it out and put a 26 in, and then we'll see the result. Do you think it's feasible? Thank you very much. Thanks a lot. It was our pleasure. It was our pleasure being with you. And I'm not telling you that we were right. I'm telling you that with this valve, we were able to perform a good implantation. And I'm pretty sure that even with the 26, the result could have been pretty similar.
You cannot compete with success. Once you have a success, this is proven the point already. Good job.
Thank you very much. Thanks and enjoy the meeting. Thank you very much. Bye-bye. Bye.
Thank you very much. Unfortunately, I think we are well beyond the time. I would like to conclude here. I thank our co-panelists, Dr. Abdullah Saidi, Dr. Abdurrahman Nabti, Dr. Abdurrahman Qahtani, Dr. Adil Kindi, and Dr. Fahad Makhdoom, and Dr. Martin Hodik. Anybody have any final comment before we close?